Leprosy. Yes, sit down. Okay. Okay. On. Okay, friends. We last time we covered the epidemiology of leprosy, the agent, host, and environment as far as leprosy is concerned, and what is the status of leprosy in the world, what is the status of leprosy in India. We did talk about the fact that India has been declared as one of the countries which has eliminated leprosy. Elimination as opposed to eradication. I'll keep on repeating this so that it gets into your head that elimination does not mean eradication. Elimination means only that it has now become, it is, as far as the government is concerned, as far as the WHO is concerned, that in this country, leprosy is not a major public health problem. I personally do not agree with the view of WHO because leprosy is rearing its head, and as I showed you, there are still a lot of cases of leprosy which are there in our country. Also, we keep getting deformities, and grade 2 deformities which are there shows that we are neglecting our leprosy cases. And the government has coolly converted the leprosy program from a vertical program. That means we had people from the headquarters to the ground level, people who are handling leprosy. That has now been merged and made into a horizontal program in which the ASHA worker or the A&M or the male health worker at the subcenter is the one who looks for leprosy cases. We are aware of what takes place in our country, and we know that such a situation is not likely to create a conducive environment for eradication. Today, I will be discussing with you mainly about examination of a case of leprosy. Now, please, since you all are not coming for clinics, this is a very important lesson for you all, very important class for you all. Please tell all your friends also who may not be listening to this lecture to come and go back and see this particular lecture, because I'll be discussing as to how you would like to examine a case of leprosy. Very simple, and I'll give you very simple steps for examination of a case of leprosy right from the beginning, that is examination of the patch. So, what are the cardinal symptoms and signs of leprosy? When you start looking at leprosy, the cardinal symptoms and signs that we look for are three. One, a hypopigmented reddish or a reddish skin lesion with definite loss of sensation. Very, very important. A hypopigmented reddish or a reddish skin lesion with a definite loss of sensation. Please remember 2 points in this. One, it has to be hyperpigmented or reddish, and second, there has to be a loss of sensation. Second is a thickening of the peripheral nerves. Thickening of the peripheral, very, very important to remember this thickening of peripheral nerve with a loss of sensation. The loss of sensation we already spoke about, but this loss of sensation may be accompanied by a motor loss also, that is weakness of the muscles of the hands, feet, or face. So initially you will have a loss of sensation, and second you will have the loss of motor loss. After you have done this, then you will demonstrate Mycobacterium leprae in the lesion. How you do this, we will discuss in today's lecture. Now, You have studied this and we have told this in our clinics. Unfortunately, many of you may not have attended the clinics in the fourth term, but remember, these are the points which you have to mention when you examine a lesion, a patch. When you examine a patch or a lesion, the first thing which you mention is the number of lesions which are there. Are there 5, 6? Are they scattered? Where are they? That is, second is the location of the lesion. It is there on the forearm, or is it there on the anterior portion of the tibial protrusion, or is it on the plantar aspect of the foot, or is it on the face? Which portion of the face? Exact location should be told. Also, when you mention this particular location, you also mention the size of this particular location, the size of this, what is the length and the breadth. Length and breadth of a particular, if you're talking about single patch, you will talk about the length and breadth of the single patch. You'll tell the exact location of this particular patch. Next, you will tell the type of lesion. What is it? What do you think is the type of the lesion? Is it a raised lesion? Is it a depressed lesion? Is it a papular lesion? Is it a macular lesion? Is there a loss of skin, a loss of hair on that, or is there a loss of sweating on that? These are very, very important as far as description of a lesion is concerned. When you see it, the first things, number, location, and type. Type is very, very important, because moment you saying that a patch does not have hair, there is decreased amount of pigmentation. There is also it merges with the rest of the area, then we are looking at a patch which is likely to be a case of leprosy. Also, if it does not have any sweating. Next, the skin. The skin around, which is around this particular area, as we were talking similar about type and skin would be similar. But what the skin around this area, how is it? What is the? Next we come to sensation. And when we talk of sensation, we talk of various aspects of sensation. I'll cover the rest, and then we'll come back to sensation. Borders. The borders which are there are something which really needs to be looked at. The borders does the border merge with the rest of the skin's surface? Is the border raised? Is the border ulcerated? Is the border having any other differentiation? Is it reddish in color? Has it got papules on it? These are all the things which I must mention about the border. The border is very, very important. Is the border having a specific cutoff point, or is it just merges with the rest of the skin? Then you will come to nerve to the patch. Every patch in leprosy would have a thickened nerve coming to the patch. We'll talk about this a little later. But go around this particular lesion. Go around the particular lesion. Keep on rolling it with your thumb. Roll the area around the lesion with your thumb to see whether a nerve is thickened around anywhere. A nerve which is leading to this particular patch, is it thickened or not? And next you will come to the muscle wasting. The muscle wasting as such will take place only later when there are motor problems with the lesion. I will not go into details about muscle wasting. There is a chapter in itself and I would not like to go into. But yes, the portion which we missed out, that is sensation, I would like to take up again. Now, when you talk about sensation, there are various types of sensation that you're looking at. Yeah, what you're looking at is sensation of touch. First is sensation of touch. Now, touch which you have got deep touch and you have got superficial touch. Now, the sensations will be measured with first thing which you will do, take a wisp of cotton and tell the person to close his eyes or look some other way and keep on touching the skin of where he has got a patch, and on the sometimes on the patch and sometimes on the surface which is normal, and try to find out whether the sensation is lost or not. Wisp of cotton, that is light touch. Deep touch is you will take a broad object which you can put over there onto that particular patch and touch for deep touch. Then you will look for pain sensation. You will take a pin and try to see whether the person feels the pain. The next is to look for sensation of heat and cold, and for this you need two test tubes, one with warm water, not boiling water, warm water, and one with normal water, and put these particular tubes onto the patch or onto the normal surface and try to tell the individual to tell whether he is feeling a heat or pain. The other sensations of vibration, etc., we do not expect to lose during with leprosy. So we will not go into vibration and other features which are there. These are the ones which are minimally which you should be carrying out. Okay, so when you examine a skin lesion, you will say it is a well-defined, solitary, hypopigmented plaque, which is located on the flexor aspect of left forearm, which has got 4 to 6 centimeters, which is about 4 to 6 centimeters, 4 inches in length and 6 centimeters in width. The patch has got a partial loss of hair. What is missing in this? What you are missing out are the borders, the sensations, the motor test. This is covered only the 3 or 4 aspects at the beginning of what I had mentioned earlier. So this is what a patch looks like, and yes, if you notice, this is 2006. This was when I was posted at I was at Armed Forces Medical College. These slides are of that time. Nothing much has changed since that time, so most of my slides continue with that. So you see this particular patch which is there, and you see how it has been described in the earlier slide. So you can also, after that, you have to mention about the regularity or irregularity of this. An irregular, ill-defined, hyperpigmented scar of skin biopsy, size 1.5 into 0.0 centimeter. Then you will also mention the sensation, that is loss of temperature, cold and hot, touch and pain sensation in that particular area. Also, you will mention about the nerve to that area, thick, non-tender. Now, the nerve can be either tender or non-tender, so you have to mention about that. A thick, non-tender nerve to the patch is palpable proximally. Okay. So this is how we can see. You can see the track of the nerve which is there in this particular slide, which will be there in. Normally, most of the time, the nerve will be proximal. So you have to see that you have to look for a nerve more on the proximal portion of the patch. Now we come to another important aspect of this lecture is, which are the common nerves involved in leprosy? this was a normal lecture, I would have asked the class to mention the nerves. But since I have got two of my PGs here, I'll ask them, please mention one or two. Now, loud. One, you tell one at least. Which are the nerves which you would like to palpate? Tibial nerve. You know how to palpate it? Which one? Ritika? Okay, let's go into what are the nerves? Common nerves. The common nerves which are to be palpated are the median, the ulnar, the radial, the common peroneal, the posterior tibial. These are very common nerves to be seen: median, ulnar, radial, common peroneal, and posterior tibial. Now there are very many more. Which are there: the supraorbital, the greater auricular, the supraclavicular, the superficial radial, the sural, and the superficial peroneal. So you will palpate all these nerves when you do an examination. If the patch is there on the forearm, it is not that only this particular, only the you will see the tibial or the radial, the radial or the ulnar nerve. No, you will look at all the nerves, which superficial nerves, sensory nerves of the body, which I have enumerated. I will try and cover many of them and tell you how to look for these. The others are simple, so many of them I may not show. Some of them may not show. Please note down this particular list of nerves which you will be showing. I'll again repeat: median, ulnar, radial, common peroneal, posterior tibial, supraorbital auricular, supraclavicular, superficial radial, sural, and superficial peroneal. Please remember these nerves. You have to know all these nerves. When I ask you in the exam, please don't stutter for these. These should come automatically to you. These are the nerves which you have to palpate. Okay. Now, how do you test for all these nerves? I'll just give you a demo of some of these. Since you are not coming for clinics, this would be very useful to you all. Okay. The median nerve. The median nerve is thickened and felt medial to the palmaris longus. Do you remember the palmaris longus? The median nerve is felt. I will possibly have a photograph of that, so I will show it to you later. And what does it supply? It supplies the radial three fingers, these three fingers, and the radial palm, okay? Radial portion of the palm, this portion of the palm, and radial three fingers. Muscles that it supplies are the flexors of the forearm and the two lumbricals. The ulnar nerve, felt in the groove of the medial epicondyle. We'll show you a photograph of that. And it supplies the little and the ring fingers. And the muscles that it supplies are the lumbrical interossei, and you remember the claw hand. The claw hand which takes place when the ulnar nerve is involved. You've been I think in physiology you've been shown this thing. Radial. Now the radial is in the radial groove. Ulnar in the ulnar groove, below the groove of the medial epicondyle. Radial in the radial groove, and supplies the first dorsal interossei and the extensors. So once that is affected, you have a wrist drop. The greater auricular is the one which is upper third of the sternomastoid and supplies the auricle and the mastoid region. It does not supply muscles. Then you have the common peroneal, or the deep peroneal as it is called, is you will see it on the neck of the fibula, and supplies the lateral side of the leg and the dorsal of the foot. Also supplies the muscles of the extensors of the leg. So whenever that is affected, you get a foot drop. And the posterior tibial is between medial malleolus and the calcaneum. I can't put my foot up, otherwise I've shown you. Between the medial malleolus and the calcaneum. And the sensory, this thing is the posterior leg, the heel and the sole of the foot. The small muscles supplied are the small muscles of the toes. Please remember this. Whenever you get a case of leprosy for your exam, we will definitely ask it. And second is, don't forget about exam. You as a doctor have to know these particular nerves. Whenever you see a patch, you must feel all these particular nerves. So now here is how you would examine the median nerve. As I told you that the median nerve is to be felt medial to the palmaris longus. The palmaris longus tendon which is there, you feel it medial to the palmaris longus. Okay, is that clear? Median nerve. The ulnar nerve in the ulnar groove which is there, you will feel it over there. So the ulnar nerve. And the radial nerve, the ulnar nerve, this is again another way of being shown the groove which is there, and the examination as to how we must carry out the examination of the ulnar nerve. Is that clear? Now, this is again another ulnar nerve examination. When you want to examine both sides together, you can make the patient put both hands in front, flex his hands, and then you will be able to see the feel the ulnar grooves of both sides together. You see that is one of my medical assistants who is examining. When I was at AFMC, I was taking the photographs at that time. The ulnar cutaneous, not mentioned, but it's another cutaneous nerve which requires to be seen. You can feel the ulnar cutaneous on the ulnar side of the wrist against the feel it against the ulnar, and you will be able to feel the ulnar cutaneous nerve. The superficial radial. Now the superficial radial nerve is felt, not the radial nerve, this is the superficial radial nerve and the radial groove which is there, while the superficial radial is felt at, behind the wrist. It is you can see where the location it is. Roll your finger over there and you will be able to feel the superficial radial. Greater auricular. Now greater auricular, what did I tell you? You must make the person look the other side and feel it on the sternomastoid. You will find the greater auricular nerve. Greater auricular nerve. Here you can, of course, you can see a much thickened greater auricular nerve over here, a very, very thickened one, and you hardly get to see like this nowadays. Nice photograph. The common peroneal nerve, as I said, you must feel it over the you can feel it over the fibula, over the head of the fibula. Common peroneal nerve. The posterior tibial nerve between the malleolus and the calcaneum, you will medial malleolus and the calcaneum, you will be feeling it over there. The posterior tibial nerve. Supraorbital. The supraorbital nerve to be felt on the ridge of the eyebrow. Ridge of the eyebrow, you move your finger upwards and you will feel the supraorbital nerve. Supraorbital nerve. The infraorbital nerve, which is there below the eyes, you roll your fingers and you will be able to see the. You will notice that some of these have not been mentioned in my list, earlier list. But these are the ones, these are also important ones, and these are the ones which commonly get thickened. So you might as well remember these. Now supraclavicle, on top of the clavicle, clavicle, expose the clavicle and roll your fingers over there, you'll get the supraclavicular nerve. Okay, I hope everyone is clear as to examination of nerves, which is very, very, very important. Now, once you have examined the nerves, then we come to the feature of the bacteriological examination. Now, the bacteriological examination is very, very important because we want to classify this particular individual into the various stages of leprosy, which we will just mention after we examine. You have been taught about bacteriological examination in your microbiology, but possibly how to take the samples has possibly not been covered. So we will cover this particular portion in detail of how to take the sample. Very, very important. You must know how to take a sample. Please don't expect a dermatologist to take the sample. You, as a doctor, should be able to take the sample. It's very simple. Very simple. So what do? We can take skin smears. As I told you that leprosy is transmissible by aerosol and through nasal secretions. So nasal smears or blows, these are the ones which are taken, or nasal scrapings. These are the three things which are taken for bacteriological examination. And once we do that, we stain that film. We take the things, make a smear, and then stain the film, and then we decide on the bacteriological index and the morphological index. This is what which I'll teach you how you're going to go about it. So bacteriological index, you have got the Ridley logarithmic scale, and morphological index, there are criteria. We will talk about criteria. So now this is how you carry out a slit skin smear. What you're doing is holding the lobe of the ear with your hand, and then slitting it, and then scraping that particular portion which is there, which is exposed portion, with your knife, and then taking that sample onto a slide. This is shown over here in the photographs over here, very clearly shown. Please compliment me for the photographs which I have made. So yeah, they're good photographs which clearly show as to what is to be done. So please remember, you are supposed to take slit skin smear from 7 sites. 7 sites. 1 is from the nasal septum, 2 samples from the earlobes, and 4 samples from the skin lesions. So even if the skin lesion patches in the forearm, you will take 7 samples. 4 you will take from the skin lesion, 2 you from each earlobe, one earlobe you can take, or you can take 2 from one earlobe. Up to you, I'll leave it to you. Generally you take it from one earlobe, and 1 is from the nasal septum. This 7 samples are to be taken, 7 sites. So skin is pinched between finger and thumb. A 5 millimeter long and 2 millimeter deep incision is given by a sterile scalpel, and the sides are scraped by keeping the scalpel perpendicular to the incision. Very, very simple, easy to be done. It can be easily done, and you can get these particular samples. Please, whenever you are attached to dermatology, kindly ensure that you do this yourself. So then, after that, we examine the samples for the bacteriological index, and this is WHO classification for the bacteriological index. Bacteriological number of pluses given to each smear divided by the number of specimens collected will give you a bacteriological index, because you are taking 7 samples, isn't it? So 7 samples, you take out the each slide will be classified, and then you take a average of these particular slides. Negative is when you don't see any bacilli. 1 plus is when you see 1 to 10 in 100 fields. 2 plus is when you see 1 to 10 in 10 fields. 3 plus is 1 to 10 in each field. 10 to 100 is when you have 10 to 100 bacilli which are seen in each field, then you call it 4 plus. And 100 to 1000 in each field, then you call it 5 plus. And greater than 1000, you call it a 6 plus. So please remember this bacteriological index. Morphological index is a little different. You count the percentage of solid staining bacilli, and because why are we looking at the solid staining bacilli? Because of the fact that only the solid staining bacilli are the ones which are viable. Some are already, there are some which have outlived their life and they're the dead bacilli, or they're the waning bacilli which are there. We do not really want to count them. So only the solid staining bacilli are counted. Morphological index is liable to a lot of observer variation, because some person may feel that it is solid, some person may feel that it's not solid. So there's a lot of observer variation, and therefore it is not very reliable. So you require people who are well trained to do the morphological index. I wouldn't expect you all to do morphological index, but you all should try. But the importance of morphological index is there because the response to treatment or the resistance to chemotherapy, this is something which we can make out from the morphological index. And also those people who are defaulting on treatment, because you will have more number of solid staining organisms in all these particular cases. If the response to treatment is poor, or the resistance is there to chemotherapy, or there is a default on treatment, you will find that the morphological index which is there is becoming poorer. What are the characteristics of a viable bacillus? A viable bacillus is one which has parallel sides, ends rounded, uniformly stained, and length is 5 times the width. There's another thing which nowadays we look at is solid fragmented granular percentage. I will not go into the details of that. Those who are interested may go and study this particular thing. Bacteriological examination, you can also do a few things, especially you can do a foot pad culture, very rarely done. Foot pad of mice is used, very rarely do we do a foot pad culture. Histamine tests are done. Also, if you really are going into research, you will possibly do a histamine test. Biopsies we have already talked about, and immunological tests also are rarely carried out. But you can do these things also. But thing which can be done for detecting the cell-mediated immunity is a Lepromin test. And what is a Lepromin test? Lepromin test is you inject 0.1 ml of Lepromin. It is given intradermally, and you look for the reaction. There are two reactions. One is the Fernandez reaction and one is the Mitsuda reaction. The Fernandez reaction takes place early, that is within 48 hours. There is a red area of a diameter which is greater than 1 centimeter or 10 millimeters, 1 centimeter, same thing. So Fernandez, that is called a Fernandez reaction. While the late reaction, that is after 21 days, is the Mitsuda reaction, where you find a nodule of diameter of half a centimeter, 5 millimeters. That is a Mitsuda reaction. You can carry out this if you want to really do find out about cell-mediated immunity. This is also important from the point of view of exam, because Lepromin test keeps coming in the exam. So please remember to read it up and write about it. For the humoral response, you got various other tests which are done. Done means these are tests which are available, but whether we really go do it, I will not. I have not seen very many institutions doing it. But if you want to do, there are fluorescent leprosy antibody adsorption test, monoclonal antibody tests, antibody competition test, radioimmunoassay test, and ELISA test. So these can test for the humoral response, and we'll get an idea about what is the humoral response. And then after you do all this, you can then decide how to classify this particular leprosy. There are three common ways of classification of leprosy. Two which are international, that's the Madrid classification and the Ridley-Joplin classification, which I had learned during my undergraduate days also. Not much has changed in that. The Madrid classification classifies as an indeterminate, tuberculoid, flat, tuberculoid, flat and raised, or borderline and lepromatous. Ridley-Joplin's classifies it as tuberculoid, borderline tuberculoid, borderline, or many times known as borderline, and borderline lepromatous and lepromatous. So two classifications, Madrid and Ridley-Joplin's classification. But in India, we have people who do not have a patch and land up with leprosy. That is a pure neurotic type, and that is the reason why in India we have classification is slightly different. We have indeterminate, tuberculoid, borderline, lepromatous. These are all similar to Madrid classification, but we have added a pure neurotic type. So otherwise, the operational classification which is there, really if you look at it, we can keep on classifying like that. But what we require is classification for the treatment point of view. And for treatment point of view, we require to classify either as multibacillary or paucibacillary. And that we can do from a skin smear positivity. We decide whether it is multibacillary or paucibacillary. Now, what are the deformities in leprosy? Deformities which you see in leprosy are very, very important, because the moment you have deformities in leprosy, you know that a patient is not being treated, has not been treated for long, or has defaulted in treatment. For a leprosy deformity to occur, it takes years. And that means for years the patient has been neglected. So what are the deformities which you see? Let us go from the face downwards. In the face, you have mydrosis, you have basically loss of the eyebrows, iritis, lag of thalamus, dryness of the cornea, a leonine facies, a saddle nose, that's a depression of the nose, and a sagging of the skin. So these are things which can take place in the face. In the hands, if it goes on to the motor system, then you have claw hand, wrist drop, trophic ulcers, because person has got a sensation loss, but despite that no action has been taken. So trophic ulcers and resorption of the fingers. In the feet, you can have foot drop, claw toes, trophic ulcers, and resorption of the toes. Okay, we will stop here. This is what we are going to cover next time, whether leprosy is eradicable or not. What are the criteria for eradication of leprosy? What is the treatment for leprosy? I don't know whether I'll be able to finish it next time also, because we'll talk about what we do and how which are the drugs used for leprosy, how we treat leprosy, and what is the WHO program and the Indian National Program for Control of Leprosy. So that will do to next time. All the best. Please read up and come next time. Okay.